Welcome back, beautiful people. Here we are in chapter 14, and the emphasis that I want to go into in chapter 14 is actually virulence factors. You guys got to do a little bit of work on virulence factors. You had 3 assignments in your summary. So hopefully you're already a little primed or a little bit up on this topic. Okay. Let's get started, I think. Okay. So one of the topics that our author likes to address is the concept of resident microbiota. Effectively that we have microbiota that on our bodies that is actually essential for our health, which is interesting. But interestingly, a lot of us are carriers of resident microbiota that's not necessarily good. Okay. As we get older, our immune system does weird things in that sooner or later it gets tired of fighting a certain microorganism. And instead of launching an adaptive immune response, it ends up saying, you know what? As long as you don't get past this point, we're going to call it good. As long as you stay there. And so we end up at a stalemate of sorts. And this immunotolerance causes us to walk around with resident microbiota that's actually not healthy. And I've known of home health cases where people have had so many different chronic infections and they have been on so many antibiotics that it is understood that they're never going to get rid of the infection that they have. It gets worse than that. You can actually smell the infection on some of these patients. And it's a terrible situation. It's not even an issue of hygiene. It's just something where that microorganism is never going to be resolved through an antibiotic. So these are strange events. And so our author had a whole bunch of slides that address the way that our body ends up with some of these microorganisms. One of the best ways of doing it, guys, is to walk around with our hands, and then we go back and we touch our eyes, and bam, something that shouldn't be in our bodies gets introduced through our eyes or our nose or our mouth. Fortunately, our bodies are very resilient. We've talked about the fact that our tears and saliva produces the enzyme lysozyme, which protects us from gram-positive organisms. But the truth of the matter is that we should probably be a little bit more careful than we are. Anyways, that being said, one of the microbiotas that our author emphasizes his assessment is the presence of Candida, which is a yeast, and Lactobacillus in the urinary tract. Okay, so this is kind of a new one on me. I know that Candida was, which is a yeast, was common, but being in a pathology lab lately has made me aware that this is actually another common problem in the urogenital tract. Okay, Lactobacillus. So that's important for you to know. Otherwise, I wouldn't be wasting your time with it. Okay, so please remember that. Let's see. So, what's one of the most important virulence factors? Well, probably the most important one in my mind, would be adhesion, the very first one. And the reason for this, again, is that if you can stop a bacteria or a virus or a fungus from adhering to our mucosal lining or to tissues in our body, okay, you would have effectively rendered it non-pathogenic. Adhesion is the primary step in initiating infection in our body, okay? And in order to do this, they use what's called adhesion factors, okay? So these, as our author says, these are specialized structures. They're attachment molecules, and it's important to know that if our body, if the organism did not have these, then it loses its ability to adhere to the cells of the body, and consequently, its ability to cause infection. So this is foremost one of the most important aspects of infection. So take Neisseria gonorrhoeae, for example. Neisseria gonorrhoeae has incredibly long fimbriae. Those fimbriae are they're attachment molecules, they're adhesion factors that are very specific. They can attach to the urogenital mucosa or to the pharynx of the body. That's it. Okay? So they're not only do they provide attachment for the organism, it also specifies where that attachment is going to take place. So that's important to know. Here's a transmission electron micrograph of bacteria adhering to a host cell. And here's the author's rendition of the same thing. And you can see that the host cell has a glycoprotein, as we all do. And here's the E. coli having attachment proteins that are specific for that glycoprotein receptor. So there you have it. It's created an attachment, and now it can subsequently introduce itself into the cell. So that is always an issue. Okay, let's keep on going here. The next topic I'd like to cover is the concept of symptoms, signs and symptoms. Okay. By definition, symptoms are subjective. In other words, it's what the patient is telling you. Signs are objective. In other words, it can be measured. It can be seen by an alternate individual in the room. It can be quantified. Those are signs. Okay. So it's important for you to remember the difference between those two. So here's examples. Okay. Signs is swelling, rash, redness, vomiting, diarrhea. All these things are we're leaving stuff out, like some, hopefully they have blood pressure in here. But anyways, anything that can be measured by an instrument or seen objectively, that is a sign. What the patient tells you, which is challenging because you don't know exactly what it means. You know, when somebody says that they're walks into a clinical environment and says, "I'm dying," what exactly does that mean? Does that mean that they have a headache, or does that mean that they're about to lose consciousness? Symptoms are terrible. They're very hard to discern, okay? But a patient could be feeling pain or nausea or headache. One of my favorite ones is malaise. Malaise. What is malaise? Malaise is French for I don't feel well. Well, I feel malaise all day long, probably because I want to take a nap. But that is a symptom. It's very hard to assess symptoms. So consequently, we want to err on the side of signs, which are objective. So please remember the definition of those. That's important. Okay. Let's go on to, okay, virulence factors. All right. So this is a comprehensive list of them, and it's a very good list. If you want to know what causes microorganisms to be pathogenic, this is the list that you're looking at. Okay. And see what we start with? Adhesion. They have to associate with the tissues of the body or the mucosa of the body. They have to start working synergistically to form a biofilm. And after the biofilm is produced, then pathogenic genes start to be expressed. They start to release extracellular enzymes. These could be endotoxins or exotoxins. We're going to talk about that in just, give me a second here. Extracellular enzymes. These are enzymes that can break down different tissues in the body. They can release toxins. These could be endotoxins or exotoxins. That's what I was trying to say earlier. And we're going to hit that in just a second. And then this is terrible. These are anti-phagocytic factors. So again, your body is trying to resolve an infection by phagocytizing the culprit, breaking it into pieces, and then doing what's called antigen presentation and going, hey guys, if anybody runs into somebody wearing this, be sure to kill it, okay? That's antigen presentation, and that can only take place after phagocytizing the culprit. So when these organisms have factors that prevent phagocytosis by your immune system, that undermines your immune system, and that's a big problem, okay? So those are the 5 most important items. We've already covered adhesion factors. We covered the biofilms before. So we're going to go into extracellular enzymes. Okay, they're actively secreted by the pathogen. They are used to dissolve some molecule in the tissues of your body. Okay, and the main role of these enzymes is to have the pathogen either hide itself from your immune system or allow the pathogen to enter deeper into the tissues of your body. Okay. Let's see. Let's go into them first. Okay. So here's one of those enzymes. This is hyaluronidase and collagenase. Okay. So if this doesn't sound familiar, think of hyaline cartilage. Hyaline cartilage, the soft cartilage in your joints. So hyaluronidase, here it is, hyaluronidase. The suffix ase means it's an enzyme. What does that enzyme do? It breaks down connective tissue that is similar to hyaline cartilage. Collagenase does the same thing, okay? This hyaluronidase is important because it is one of the most powerful enzymes to allow the organism to enter deeper tissues. And that's important to remember. Collagen, okay, collagen is also another structural enzyme. And again, collagenase is the enzyme that breaks down collagen. Here's more enzymes, but they do different things. We have coagulase and kinase, okay? So the bacterium can release coagulase, which causes a blood clot, a local blood clot around the organism. And what the organism is doing with this is preventing your immune system from identifying it and attaching to it. Okay. Once the organism believes that it's escaped, that it's evaded your immune system, then it releases kinase. This kinase breaks the clot and it allows the microorganism to, again, burrow further into the tissues or go further down the circulatory system. So again, this is hide and evade. Hide with coagulase, evade with kinase, okay? And to recap again, hyaluronidase is probably the number one, you should remember that, it's probably the number one way to enter the tissues of the body. Okay, so let's take a look at this. See, here's hyaluronidase again. Breaks down the tissues of the body, okay? Look at these, look at this. This is Staphylococcus aureus. Here's epidermidis, okay? I always tell people that this is the guy that misbehaves. This is the nicer one, okay? Look at all these different enzymes and all these virulence factors that Staphylococcus aureus has. See that? It has everything. It can get into the tissues. It can evade it. It can fight your immune system. It can break down antibiotics. It can break down fats. I mean, this is a very poorly behaving organism. Epidermitis, not so bad. If you have a problem, it's going to be Staphylococcus aureus, especially if it's antibiotic resistant, such as MRSA or VRSA, vancomycin resistant Staphylococcus aureus, or methicillin resistant Staphylococcus aureus. Okay, now we're going to go into the next one. What have we covered? We've covered adhesion factors. We've covered biofilms. We just covered extracellular enzymes. Now we're at toxins. Okay, we're at toxins. And toxins are a challenge, okay, because once a microorganism creates a toxin, those toxins have a tendency to be heat stable. I talk about this because there's a lot of people that take food that is questionable, and they say to themselves, well, if I heat it or boil it, it'll be okay. No, that's not true. If you heat it or boil it, you will kill the bacteria, but the toxins that have already been released by that bacteria are probably heat stable and will still reside in the food. So 99 times out of 100, when people have gone out to a restaurant and ended up with food poisoning, they heated the food before they gave it to you. There is no bacteria left in that food. However, the toxins produced by that bacteria for the last day or two are obviously in the food, and that's what created the nausea in you, okay? So toxins are a challenge. If the toxin is created by the bacteria and purposely released to the outside, that's called an exotoxin. If the toxin is part of the bacteria itself and it only gets released to the outside, once the bacteria breaks, then that's called an endotoxin. So an example of an exotoxin would be a neurotoxin, something that gets released into the bacteria to disrupt your nerves. An example of an endotoxin is lipid A. Lipid A is inside the bacteria and is not going to be released until the bacteria dies. But once it gets released, it causes a lot of problems. Okay, lipid A is one of the most powerful toxins out there, and it creates disseminated intravascular coagulation, and petechia, lower blood pressure, shock. I mean, this is a bad guy right here. Okay, so here's another example of an exotoxin that's being released. Okay, this is called a cytotoxin. And when the toxin gets released, the role of that cytotoxin is to kill bacteria to allow the bacteria to go to lower tissues. Okay, so again, exotoxin, purposely being released by the bacteria. Okay, here's an endotoxin. Okay, so again, the bacteria gets phagocytized. After it gets phagocytized, it lyses. Because it lyses, the lipid A endotoxin gets released, okay? You can see what it does. It creates fever, inflammation, diarrhea, shock, and this should not read blood coagulation. It should read disseminated intravascular coagulation. In other words, this is coagulation of the blood that is systematic throughout the system. It's a big problem. Okay, so there's examples of an exotoxin and an endotoxin. Okay, looks like we have one last thing to talk about, and that's antiphagocytic factors. Okay, so antiphagocytic factors, there's two flavors. There's two flavors. So imagine that you have a bacteria and you have a macrophage or a dendritic cell. Okay, the dendritic cell, its job is to phagocytize that bacteria, break it up, break it into small pieces, and then carry out what's called antigen presentation. Hello, if you find this, kill it. Okay. So the two motifs is you can actually have antiphagocytic factors that prevents the dendritic cell from attaching to the bacteria. That's one problem. Another problem is that the dendritic cell does phagocytize the bacteria, but then inside the dendritic cell, that bacteria has to be broken down. And the way that we do this is we bring in a vacuole full of hydrolysing enzymes called a lysosome. And that lysosome is supposed to get together with the vacuole that has the bacteria, which is called a phagosome. And they're supposed to join together to form the phagolysosome. And then those enzymes come in, they break down the bacteria, and then we process the bacteria to show it off. Well, what happens in these antiphagocytic factors is that the bacteria actually has a mechanism to prevent the phagosome from attaching to the lysosome. Is this a problem? Yes, it's huge. Because now, not only have the bacteria gotten into the dendritic cell, they're just going to live there happily, knowing full well that the lysosome is never going to attach to it. So in that instance, the part of your innate immune system, which is supposed to protect you, has now just become just another infected cell. So that's a big problem, okay? So there you have it. You can have a bacterial capsule composed of chemicals not recognized as foreign, which are slippery and difficult to consume, to phagocytize. Alternatively, you can have antiphagocytic chemicals that prevent the fusion of the lysosome and the phagolysosome. Okay? And then, as if that wasn't enough, they can also produce what's called leukocytins. Leuko means white blood cell, cytin means to kill, which destroy the phagocytic white blood cells. This is terrible stuff. Okay. So here you go. Here's one more. I don't know how I keep on doing that. Let me try it again. Here's one motif. Okay. The organism can have a very slippery capsule that makes it very difficult to engulf, or it can be engulfed, but the lysosome ceases to come together with the phagosome, and now the bacteria thrives inside the infected dendritic cell. Wow. Scary stuff. Okay, last topic, I think, has to do with illness. So it's important for us to grasp the stages of illness. Incubation. Incubation is that period in which we are infected, but no symptoms have manifested themselves yet. Prodromal, we now know that we're sick and we're increasing in illness. Illness is the climax. That's the worst, the point at which the infection has maximized itself. The decline is when the immune system or antibiotics or both are resolving the illness and it's decreasing. And then convalescence implies that the illness has been resolved, but your body still is trying to heal itself from the stresses of the illness. So you have your incubation, no signs or symptoms, prodromal period, vague general symptoms. I'm funny in that I'm really dumb when I get sick, can go through a prodromal period, and I'm like, I'm just tired. It's just been a long day. It isn't until I get shut down and I can't stand up anymore and I go, oh, I'm sick. So it takes a lot for me to realize that I'm sick. So I go through a lot of prodromal periods thinking that I'm just tired. But you have vague general symptoms where you know that you're getting worse. The illness is the climax. Once the illness has been resolved, we go into the decline. And then once there isn't any more infection, but your body is trying to resolve itself and heal, that's your convalescence. What's the worst part? The worst part is, of course, the illness. Okay? All right. And that is it for this chapter. Thank you for your attention. Thank you for allowing me to do the quiz one day late. And have yourself a wonderful day, okay?